Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 147, Fluid Balance. This episode is prompted by the fact that in the UK we're having a few weeks of hot weather. And for us, that can be a little bit of a novelty. And one of the things I see on social media and bandied about a lot is drink, drink, drink. Encouraging our women not to get dehydrated. Carry water with you. Drink water. Keep yourself hydrated in this heat. And that is correct messaging. But whilst we would think drinking water, one can't do any harm doing that, surely, actually one can, particularly if you drink excessive amounts of water in labour. Therefore, this week I thought I would do an episode on fluid balance. What fluid do we need? What is the impact of labour on fluid balance? And how much should we be drinking? And is there an upside and a downside of telling women to drink? And don't get me wrong, I've done it myself. I've walked into the labour room and told women to drink. So to talk about this, I'm going to go back to the beginning. When I was a medical student, we were taught a bit about fluid balance. That is how much the body needs in terms of fluid intake in a 24-hour period. This is particularly relevant in surgical specialties where people may not be drinking in the way that they would normally. So we had to learn and understand how to manage and give people the right amount of fluid if they were nil by mouth, so they weren't able to drink. We had to think about what was their input, their intake, so what we were giving them intravenously or through drug treatment, and then what was their output, so how much urine their kidneys were producing, maybe they were vomiting, maybe they were having diarrhea, or maybe they had surgical drains that were removing fluid from the body. But we also had to think about what are called insensible losses, where actually you lose a bit of fluid breathing in and out or sweating. So you'd need a bit more fluid if you had a high temperature or if you have a raised respiratory rate. So what we were taught as medical students is that on average, the average sort of size person, and bear in mind this does depend on the size of the person that you are looking after, needs around 2.5 to 3 litres in a 24-hour period. And the type of fluid we would give would depend a bit on what was wrong with the patient, because if a person is vomiting excessively, they would need extra potassium because you lose potassium ions in stomach contents. So we would give something called normal saline, so sodium chloride mixture with potassium on the surgical wards. And then we would have to modify the amount of fluid we were giving depending on what was going on with the patient. So the 3 litres was kind of the starting point, and we'd need to put that up or put that down depending on perhaps their kidney function, their heart function, because there are some conditions in which you need to be very careful when you're giving intravenous fluid. So that's our kind of starting point of what someone might need. Pregnancy comes with its own set of problems. There's much discussion about whether women should be eating and drinking in labour, and in general, the consensus at the moment is that they should and can eat and drink as normal. But there will be situations in which we want to give intravenous fluids. Maybe there are signs of an infection, the woman's pulse is going up, she's got a high temperature, or she's vomiting, she's unable to drink and keep down fluids taken by mouth, so we might give intravenous fluids. And then there's also the situation that she may be bleeding, in which case we want to replace the blood volume that is lost. Or sometimes we've used fluids when we have concerns about the baby's heartbeat and a woman's blood pressure drops. We've given a fluid challenge to try and help improve placental circulation and improve the baby's heartbeat tracing. But on top of this, whether a woman is drinking or whether we are prescribing fluid, there are changes in pregnancy which mean that it is easier for a woman to get so-called water intoxication or hyponatremia, that is a low sodium level. So pregnancy is a state of positive water balance. So gradually over the course of pregnancy, a woman will accumulate 6.5 to 8 litres of fluid because of increased circulating blood volume. So hypervolemia, increase in volume of plasma and water excess. So any pregnant woman will be retaining water. And this is partly due to changes in the kidney, the way the kidney adapts and controls fluid and sodium exchange. Renal blood flow increases, the kidneys get a bit bigger, so there's some structural changes, and the filtration is hyperfiltration. So often the blood tests we look at, we accept as normal a lower level of creatinine and urea that are filtered by the kidneys because the kidneys are actually functioning better than they are out of pregnancy. And the same is true with sodium. The sodium level of a pregnant woman will be slightly lower. So accepted as normal is 130 to 145 compared with a non-pregnant woman, which would be 135 to 145. So pregnancy creates what's called a physiological hypervolemic, so that means more fluid, hyponatremic, so less sodium state, which is fine. That's the way the body's adapting to pregnancy and doesn't cause any problems to women and goes largely unnoticed. However, there are then changes on top of this in labour, and this is because of the effect of oxytocin. So the same hormone that is helping you contract and labour, oxytocin, has an antidiuretic effect. So it actually means that the woman will retain more water. And that's because the oxytocin is very similar to something called ADH, which is a hormone that acts on the kidneys. So there's some cross reaction. So this may reduce a woman's urine output in labour. So women in labour, particularly those in labour for a long time, may start to reduce their urine output and retain more fluid. So it's particularly important that we keep an eye on their fluid balance, so how much they're drinking, how much fluid we're giving, and what's their output, how much urine are they passing. And we can, if a woman has a long labour or we prescribe oxytocin drips for a long time, perhaps if she's having an induction of labour, we can predispose that woman to being at risk of hyponatremia, so a low sodium level. And this can have an impact for both the mum and the baby. So we need to be very careful in labour. So particularly a woman that has a long start to labour, maybe is in labour over a few days or is having an induction over a few days. The woman might be nauseous, vomiting, encouraged to drink to kind of counteract the dehydration. May not feel like eating, which also can have an impact. Maybe she's using Entonox for pain relief, so she's breathing in and out quite heavily, or experiencing a dry mouth from that. And it's difficult for the woman to balance, and it's difficult for us to balance. And then we might end up giving intravenous fluids excessively because of concerns about the baby's heartbeat, which is something we're really trying to move away from. And therefore, these women have a higher risk of water intoxication. So that is having excessive fluid and low sodium. So it's incredibly important in labour for midwives, as part of the care of any woman, to be looking at the input-output, the fluid balance. And we need to look at this on our ward round. And we're not as good at it as we should be, ideally. So a lot of us have become a bit more aware of this in recent years because there was a study published by the UCOS, the UK Obstetric Surveillance System, to look at women with symptomatic hyponatremia, so sodium lower than 125 in labour or the immediate 48 hours after delivery. And this was because there was some cases in the UK of hyponatremia. So from the NHS Resolution Early Notification Scheme and the UK Obstetric Surveillance System, it was discovered that actually this complication of low sodium, not only in the mother but in the baby, was potentially at risk of causing brain injury to affected babies. And therefore some work was done, and there's a great article in The Obstetrician and Gynecologist, which I will link to, but you might need to use your institutional login if you're a healthcare professional, and I will link to some other information too if you're not. So it's really important for us to measure and keep an eye on fluid balance in labour. And if there's a difference, a positive balance of 1500 ml, so that's 1.5 litres or more, then we need to look at the woman's sodium. So we need to measure her kidney function. And we'll often do this in labour with women with blood pressure problems, or perhaps they're not passing as much urine as we think they should be. But we also need to think about the fluid balance. So a woman with low sodium may start to have symptoms. They may have headache, they may be feeling sick, very lethargic, but worst case, they can become disorientated or have a seizure. And that's important for us to know about, because in pregnancy we often assume any seizure is eclampsia, but actually a low sodium could be a cause of a seizure. And this is because sodium helps stabilise the membranes of neurons, the nerve cells within your brain and nerves. So it's very clinically important. So we need to keep a very close eye on the fluid balance in labour. And I'm thinking about that particularly this week when it's super hot and women are drinking loads. And I certainly see women on the labour ward at all times of the year, but particularly in the heat, that are drinking loads and may get themselves into a situation where their sodium is low inadvertently. And when you ask them, are you drinking because you're thirsty, or are you drinking because you think you need to drink? And they're often saying, I'm drinking because I've heard that I should keep myself well hydrated. That will keep my labour going. You're encouraging me to drink. So we need to be careful that we're not doing harm by telling women to drink. So if a woman has a low sodium, then there is now a kind of recommended guidance of what we should be doing. And whilst it's a rare problem, it's a preventable problem. So we should be able to manage it and prevent complications for mum and baby. So the first thing we need to do is, for all women, keep a careful eye on their fluid balance. And then if they're in a positive fluid balance, or if they have signs that could be hyponatremia, which can be difficult to diagnose because some of the symptoms could be the same as other things in labour, then we need to check their blood tests and look at their blood sodium. And if the blood sodium is more than 130, we're okay, it's normal. Yes, we need to keep a bit of an eye on it. We may need to repeat it again, but that's okay. But if the blood sodium is between 125 and 129, then actually we need to fluid restrict this woman, make sure that that any fluid she's having, whether that is drinking or whether that is intravenously, needs to be kept to around 30 millilitres an hour, so half a mil an hour per kilo, roughly, depending on the weight of the woman. We need to stop syntocinon if we're using it, because that's going to worsen things. And then we need to recheck her blood tests in a couple of hours. And then we also need to inform the neonatal team, because they're going to need to monitor the baby's sodium levels after it's born. If the sodium level is less than 125, then this is a real emergency and needs multidisciplinary input from not only the obstetrician, the anaesthetist, but also potentially critical care, medical teams, and obviously the neonatal team. And you can use saline, hypertonic saline, for women who are symptomatic and who need quicker correction than fluid balance might allow. And we need to also be aware that acute kidney injury, hemorrhage, or excessive bleeding and infection can be complications that go with the low sodium. So it can be difficult to manage all these different competing problems together. We are also conscious that some women with low sodium, preeclampsia can induce a low sodium, and this is when we see low sodium antenatally before labour, and that can be in relationship to underlying kidney disease or kidney disease induced by preeclampsia. So we need to be aware when a woman has low sodium that we ought to be looking for other signs and symptoms of preeclampsia and look at her test results to ensure that, is this hyponatremia, low sodium, isolated or in relation to preeclampsia? And this can also become more complicated if a woman does have seizures who has low sodium and preeclampsia, because it may be, we've got to unpick why are the seizures occurring, and that may not be clear. So once you've identified a low sodium, you need to have fluid restriction and regular repetition of the sodium, involvement of the whole team, and be really cautious or stop your oxytocin. And usually once a woman's had her baby, things will self-correct. If you can do that fluid restriction, and it may seem really cruel because the woman may feel thirsty, but eventually her kidneys over a few hours or a few days will kind of kick in and things will bounce back and the woman will recover quite quickly. The reason that this low sodium can cause problems for the baby is that the woman's baseline sodium is lower and water concentration equilibrates across the placenta. So the baby can also become severely hyponatremic, so that is very low sodium, in the presence of the mum's fluid overload. And if then the baby is subject to hypoxia, so lack of oxygen as well, that low sodium can exacerbate and make any potential damage to the baby's brain worse, so causing neonatal seizures. So babies born to mums with a low sodium need to be checked, and they may present with symptoms and they may have breathing difficulties, low APGAR scores, and need admission to the neonatal unit. And it's very important that the paediatricians are aware and can correct this and help the baby correct this. So whilst this is a rare complication, it's being seen as increasingly important to be vigilant and think about the fluid a woman is drinking or we're giving in labour, because this water intoxication is more common in pregnancy and because it can have such a negative impact on both the health of the mum and the baby. So most units, mine included, now have a clearer guideline and a clearer pathway for what to do, how to monitor, when to monitor a woman's sodium levels, when to monitor the baby, and what to do. And we're much more cautious. We used to bung up IV fluids through a drip for any woman having almost anything, being sick, having an epidural, or having a change in the baby's heart rate trace, whereas now we're much more cautious and much more thoughtful about, does this woman need fluids? If she does need fluids, how fast or how slow rather should we be giving those fluids, and what is she drinking herself? So the upshot, the zesty bit, is yes, it's hot, and even when it isn't hot, we do need to encourage women to keep themselves appropriately hydrated as they go through labour, particularly if the labour is long and arduous. However, we should not be encouraging women to drink excessively, and we should not be prescribing fluids and inadvertently causing excessive fluid retention. Therefore, we need to encourage women to listen to their body. If they're thirsty, they need to drink. That's how their body is regulating itself. If they're not thirsty, they don't need to drink. So drink to thirst, listen to their body, and for us not to do harm by meaning to do something useful. And the same if you're pregnant and listening to this. Drink to thirst. If you're hot and you're thirsty, you're not going to do yourself any harm. You don't need to worry about excessive water intake if you listen to what your body's telling you. But if people are telling you to drink litres and litres of water, and I do see this a lot in magazines and TV programmes about well-being, drink however many litres a day. Actually be careful, because in pregnancy your body will respond to that a bit differently, and you may not be able to just pee it all out the way you might do if you go to the gym or do something else out of pregnancy. In pregnancy, your body has made some adaptations which make it harder for you to lose that fluid. So just drink what you need to drink to satisfy your thirst, and you and your baby won't come to any harm. And if we're fussing about in labour, asking how much you've drunk, or we tell you to drink a bit less, or we're looking at how much urine you've passed, be tolerant of us. Understand that we're doing this to try and keep you and your baby safe, even though this may seem slightly tangential to the care you were maybe expecting. I very much hope you found this episode of the theobspod interesting. If you have, it'd be fantastic if you could subscribe, rate and review on whatever platform you find your podcasts, as well as recommending the theobspod to anyone you think might find it interesting. There's also tons of episodes to explore in my back catalogue, from clinical topics, my career and journey as an obstetrician, and life in the NHS more generally. I'd like to assure women I care for that I take confidentiality very seriously and take great care not to use any patient identifiable information unless I have expressly asked the permission of the person involved, on that rare occasion when it's been absolutely necessary. If you found this episode interesting and want to explore the subject a little more deeply, don't forget to take a look at the programme notes where I've attached some links. If you want to get in touch to suggest topics for future episodes, you can find me at theobspod on Twitter and Instagram, and you can email me theobspod@gmail.com. Finally, it's very important to me to keep the theobspod free and accessible to as many people as possible, but it does cost me a very small amount to keep it going and keep it live on the internet. So if you've enjoyed my episodes and by chance you do have a tiny bit to spare, you can now contribute to keep the podcast going and keep it free via my link to buy me a coffee. Don't feel under any obligation, but if you'd like to contribute, you now can. Thank you for listening.